Well, welcome back everybody for our final session of the day. For this afternoon session, we brought together some healthcare leaders from across Australia to share with you some of the motivations, their challenges and solutions to implementing the Zero Suicide Framework within the health service. We're very fortunate to have our opening presenter, which is Dr. Catherine Turner, who will be known to many of us as the innovative leader of the Gold Coast Mental Health Services, which was the first in Australia to apply the 7 elements of the Zero Suicide Framework with absolute great fidelity, and has been leading reform across Queensland and Australia and overseas with the work that she's been doing. She'll be talking about some of the positive outcomes for both staff and those presenting to the service, and she's continued to build on the learning from the Gold Coast in her current role as Executive Director of Metro North Mental Health. So please welcome Dr. Catherine Turner. But just to let you know, following Kathy's introduction, we'll introduce each of the presenters just before their presentation. So welcome, Catherine.
Great. Well, thanks very much, Matt, for that introduction. So I too would like to respectfully acknowledge and pay respects to the traditional custodians of the land, which for me is the Yagara and Turrbal people. And I'd also like to recognise those with lived and living experience and their vital input into service delivery and change. So I'm actually going to talk a bit about a recent article that's been published and just what this tells us a little bit as leaders. So a recent article published by Olearis and others entitled "The Zero Suicide Approach: Style over Substance," and it critiques the Zero Suicide Framework. And in their piece, the authors present a series of arguments that often contradict themselves, I think, and setting up straw man arguments, and then they refute them without strong justification. So it might be tempting to dismiss it, but it's important to consider what it reveals about our approach to suicide prevention. So it raises questions about our clarity of our messaging, the complexities and paradoxes that we face in this field, and the leadership challenges that we must navigate. So are we clear on our messaging? How do we manage complexity and paradox? What's our role as leaders in this process? And how do we endure the inevitable challenges that come with driving system reform? So the paper presents conflicting messages really about zero suicide. It states that it's an approach is based on the belief that all deaths from suicide in healthcare settings are preventable, but it's also an aspirational target used to drive system reform. It's a concrete goal, and even they describe it as a sentinel event, which usually the meaning is that it's wholly preventable. So most of us recognise that it is an aspiration, one that challenges pessimism and nihilism, and reinforces the belief that recovery is possible for every individual. While the aspirational nature of zero suicide has been a catalyst for system change, there's often qualifiers such as journey to zero or towards zero. However, even if the authors of this paper struggle to grasp the nuances, how do we ensure that the message is communicated effectively to avoid misunderstanding and potential harm? Crucially, this is similar to discussions often lack lived experience engagement. So certainly in our work, it was lived experience leaders who said to us, well, what other goal would we have? So their voices must be central in shaping the messaging around zero suicide to ensure that it's both aspirational and grounded in real world perspectives. So the paper also talks about being narrowly focused on suicide prevention as a key indicator for mental health system performance. So that's somewhat perplexing, I think. So few of us would argue, surely, that suicide prevention is a critical measure of mental health system performance. Both the public and in general, and those with lived experience would expect it of us. So the authors suggest emphasising suicide prevention could crowd out other priorities within mental health services across different mental health conditions and target populations. Interestingly, they do accept that Zero Suicide Framework champions tailored care, but claim that the opposite may occur at the clinical coalface, diverting resources from comprehensive psychiatric formulation. So these concerns really have been long recognised and being addressed, and I'll describe that shortly. So a key principle of the Zero Suicide Framework is the need to move away from using diagnosis as a prerequisite for access to treatment, an approach that previously excluded many people from care. And the paradigm shift reinforced by the Zero Suicide Framework offers an opportunity to ensure these individuals receive the care that they need. However, this shift must not come at the expense of those with severe and complex mental illness. We do need appropriate resources for both suicide prevention and comprehensive mental health treatment. As previously we've outlined in our paper, The Paradox of Suicide Prevention, the risk of a pendulum swing in which the focus of care shifts from one approach to determining service priority and focus, such as diagnosis, formulation, risk and clinical care, to a new focus, suicide-specific and non-clinical care, potentially supplanting the previous approach. And we noted a review of planning frameworks, such as Australia's National Mental Health Service Planning Framework, is urgently needed to determine appropriate funding levels for suicide prevention and crisis care within mental health services. And importantly, addressing these needs must not come at the expense of consumers with severe and complex mental illness. The authors of the critique rightly acknowledge the mission that the mission of Zero Suicide Framework is sound and it supports critical, tailored approaches. However, they highlight the risk of poor implementation at the front line, which is a valid concern. But instead of dismissing the framework due to fears of poor translation into practice, we need to ensure that we have efforts focusing on ensuring fidelity to the model in practice. As leaders, we must recognise the potential for unintended consequences in implementing this approach. While shifting away from diagnosis as a barrier to treatment, it remains critical to maintain a strong emphasis on formulation, diagnosis, evidence-based treatments, and the role of mental illness as a significant risk factor for suicide. The authors present what I think is quite contradictory arguments regarding their use of suicide, as a measure for healthcare system performance. While they acknowledge the complexity of using suicide as an outcome, we find it difficult to defend a position of not attempting to measure it at all. We agree that understanding the socioeconomic and environmental confounders and ensuring sufficient time and sample sizes are all essential for meaningful analysis. The authors also critique the use of surrogate measures like suicide attempts, arguing that they could reduce care for individuals without suicidality. So we reiterate that focusing on appropriate, consumer-centred, tailored care is essential. Suicide attempts also can be a useful surrogate measure with the necessary caveats in mind. Additionally, they also have the emotional, physical and economic impacts for consumers and their families. So addressing and preventing these events in themselves is a legitimate and essential goal for care, so not only as surrogate measures. The authors criticise the Zero Suicide Framework for being limited to healthcare settings. The narrow focus on preventing suicide through healthcare alone is a major issue. Suicide prevention efforts must be multifaceted and involve a whole of government and whole of community approach. So we've really repeatedly addressed this concern, but the authors fail to acknowledge that. The Zero Suicide Framework is deliberately focused on the healthcare system with the understanding that it's part of the broader community-wide strategies targeting the social determinants of suicide, for example, lifespan. Their criticisms, I think, are akin to questioning the value of high school simply because it doesn't serve preschool, primary and tertiary students. The Zero Suicide Framework is a crucial component of a whole of community, whole of government strategy. So the authors describe Zero Suicide as arguably vague framework with scant evidence base, which is somewhat surprising because I think the clarity of the Zero Suicide Framework is key to its widespread adoption and helping services to implement a structured systems approach. Zero Suicide, and this is an important issue, it's a vehicle for implementing evidence-based practices. It also emphasises essential evidence-based aspects of safety that we know is associated with improved outcomes, including leadership that sends a clear vision to prioritise patient safety, culture change that fosters psychological safety and learning, and support for continuous improvement through data-driven strategies. So while I think somewhat misguided, I think the article raises important issues, not as reasons to abandon the framework, but as reminders of the complexity involved in suicide prevention work. It's essential to remain vigilant to unintended consequences and address them swiftly as they arise. So as leaders, we must be clear in our language, effectively communicating the nuanced concept of an aspirational goal while avoiding messages about concrete targets, maintain a focus on suicidality and crisis while enhancing individualised approaches to formulation, diagnosis, evidence-based treatments for mental illness. This supports excellence in clinical care regardless of suicidality. Advocate for appropriate resources for suicide prevention efforts, in addition to improvements in clinical care for those with severe and complex mental illness, and ensure that our focus on suicide prevention in healthcare settings is integrated with broader community government and government strategies, and engage in robust evaluation. And finally, leadership driving reform is not easy, but people we serve deserve our efforts. There are always strong forces that push back to maintain the status quo. It's easy to put forward a myriad of reasons for why we shouldn't do something. It's much harder to stand up and lead positive change. So we need to continue to care for ourselves and for each other to sustain this important work. Thank you. Happy to take any questions.
That was amazing. Thank you, Catherine. We will be taking questions at the end and probably take them on notice because I'm not sure we have time to fit everyone in. But I just want to say thank you, Catherine, for your dedication, your ongoing dedication and leadership in reforming suicide prevention, not just across Queensland and Metro North, but internationally as well. The reason in a lot of voices. So thank you very much for sharing that presentation and taking time out of your very busy day to share that with us today. Thank you. So next up, we have Mr. Adam Bryant, who is the Director Mental Health at Illawarra Shoalhaven Local Health District, which has been a leader among the New South Wales Health Service in implementing zero suicide. So please welcome Adam Bryant.
Thank you all very much for inviting me today. If I could just open by acknowledging the traditional custodians of the lands that I'm on today, the Dharawal people. I'd also like to acknowledge the voice of lived experience of our consumer and carers who have been essential in this work around towards zero suicides. It would be remiss of me to not also acknowledge the leadership that has been on this journey with us for the last 5 years. Julie Carter, who's the Director for Mental Health at the time we initiated this initiative, Dr. David Alcorn, who's our Clinical Director, and Caroline Langston, who's our Executive Director at the time we started this process. So today I'd like to talk about our implementation of 5 different suicide prevention initiatives, some of which we've been doing for the last 5 years, some of which are only in the last 12 months with our aftercare program, and the process that we've sort of gone through in I suppose trying to implement 5 different ways of working, what we've learned on that journey, what the benefits for that process have been. If I'll start off with probably what I think has been a real sort of quintessential part of that, which has been our Safe Haven. Now in New South Wales, Safe Havens were part of the rollout for a lot of LHDs across the state, and we really leaned into the partnership component of developing that service. We had an existing relationship with our Suicide Prevention Collaborative region that's just 10 years old, and we did a lot of our early work with them and helping developing our relationship with Roses in the Ocean and getting that consumer consultation process underway. The biggest challenge for that is we were doing all this in 2020, which was when there were lots of challenges around coordinating collaboration with our consumers. There were lockdowns on. We had opportunities to do some face-to-face, some virtual work, but what we did is get a really clear voice from everyone around, making sure that this was both a peer-led program but independent from the LHD, which was very different for us compared to a lot of services in New South Wales, and that has gone really well for us in our community. It's gained a great reputation. We've been lucky enough to have a provider now for just over 4 years in that work, and developed some really good working relationships both between the provider and our emergency department, which is obviously in line of sight from, but still a couple hundred metres down the road, and our community mental health team, which is often an escalation point to prevent the need for care in the keeping care in that community sector as well. They're obviously doing a wide range of services, including just giving people an opportunity to debrief, to provide coffee and chat or de-escalation activities, right through to suicide prevention planning. And helping people provide services that will help them both in the short term, but in the longer term. But the really key component to that was doing that collaboration with our community early on board. And that collaboration and that work was being done not by our Towards Zero Suicides manager, but by our service development manager, which allowed that person, our suicide prevention manager, a lot of freed up time because they're able to help co-lead a lot of this work and particularly around the consultation process as well. At the same time, we also did a lot of work on our suicide prevention outreach team in that collaboration and that co-design process. Now, that's been a lot of learning that we've had to do on that journey for ourselves. Now, that's partly because we had particular expectations where we heard just beforehand around a data-driven system, and the quality of our data is something we're constantly trying to refine the quality of. We initially thought that our suicide prevention outreach team would be best when people are presenting to the emergency department. But what we've found since then is that actually it's about getting it set up in the hours before that. We initially had an afternoon shift program set on up in our service at the opposite end to where our safe haven is in the district, which is about 120, 150 kilometres away. And through that learning, we identified that we actually need to be on a day shift. We always thought it was going to be an afternoon shift. But setting that up as a clinician/peer worker response has been outstanding for us. It's changed both our capacity to engage consumers, but also the culture and the assigned teams that are interconnected with our SPOT team, which are things like our acute care team, which hasn't traditionally had access to peer work. But by being in the same office environment, we've been able to really help influence around what the role as peer work can do in those crisis response programs. We were also lucky enough to get a rural counselling program at the same time, which is only one person, but having a different way of working than our traditional sort of care coordination and acute response programs in working with people and external care providers around a lot of the crisis that we've had to work with our community on in the last 4 years, whether that be bushfires, droughts, obviously that the impact of things like COVID-19 has had a really big impact on us there. And that's also been a program that we've been able to help support other communities in collaboration with things like our disaster recovery programs. They also don't take a traditional referral process. They will accept direct referrals from general practitioners outside of the 1-800 line that I mentioned beforehand with SPOT, which is a little bit different for us. And that's been really good to give GPs an alternative particularly in a more regional setting. I might come back to aftercare in just a second, but I really do need to call out our suicide prevention manager. Now, some other services, I'm aware that these roles were used as the setup process for all of the previous initiatives that I've mentioned. But by giving this role a dedicated focus around a few key initiatives, one was around our implementation of SafeSide with our education team, around making sure that we had good training available routinely to the workforce, around building those relationships with our non-government organisations and getting them on board to participate in that training with both the NGOs and our Suicide Prevention Collaborative really changed how we were able to implement SafeSide. Having everyone in the room at the same time as the clinicians really enabled a different type of conversation so that people had a shared language. And that was an amazing sort of change for us with some of those NGO providers, particularly our aftercare provider, but also some of the other NGOs that we've had longer term relationships with. It really gave them some time around the development of our suicide care pathway and setting up of our steering committees and making sure we had a good engagement with lived experience on those committees, but also how did we support what was a relatively new process for us around having a lot more participation from lived experience in our some of our really complex committee structures. Health loves a good committee structure, so it was really important to make sure that we had the right support mechanism for people as they came into that work with us. And then the last one is around safety planning and how did we implement safety planning in support of those pathways. Now, we're lucky enough to be able to develop paper-based processes, but as anybody knows, getting anything converted from a paper-based process onto our electronic medical record takes a fair bit of time, and having a person who can keep on advocating for that was really, really important. Now, because they didn't have the responsibility to set up a lot of those processes, they definitely came on board more with the sustaining of the relationships with things like our Safe Haven and a range of different NGO providers over time. But it allowed really a lot of that early work around training, around education, and around setting up those processes for our restorative just learning culture, which I'll get to in a little bit. Now I'm just going to go back and acknowledge our other part is our aftercare program. Now, when initially this sort of came on down, it was around developing our relationships with more of a process with our PHN and our PHN providers around the aftercare process. But when we've gone and spoken to both our providers, spoken to the community and to our clinical teams, we've changed these roles into much more of a clinical lead process rather than a manager-based process. They obviously have the capacity to work with the managers at the sites, but they're much more able to uh, be involved at the clinical coalface as well. And I think this is just one of those things they can help diffuse a lot of the tension out of the situation, which is just amazing for us. Um, then the question sort of comes back to what's the motivates the need for this change. Now, for me, I've always been a big fan of illness management and recovery programs, but also the recovery orientated change process that started in the NHS around 15 years ago. And I thought this was an amazing opportunity to really embed lived experience in our service development. And how do we have the honest conversation with ourselves that mental health services have had a lot of opportunity to recover, but this is a really sort of fundamental way of helping lead that change. And that recovery is both acknowledging as well as how do we recover from the trauma that our services have been through and help people learn and become that real learning organisation. And also, it's obviously a great opportunity to increase the diversity away from hospital-based processes to the community. Obviously, the benefits have been that increase in that expansion in the types of services, both in the NGO sector as well as within the health sector, and find new ways of working to get people from that point of crisis to the appropriate program for them. It's obviously been a big change in our training processes for our staff, and both with the safe side and then that's morphed into our new HEDI-based training through the statewide health education program. It's been a really great opportunity to build micro QI projects with individual teams, particularly based on these foundations. And how do we celebrate those successes with both consumers, with our carers, and with the teams when they're able to develop these processes? And what have been the barriers that we've been able to overcome? Definitely new ways of working with regards to co-design. Definitely for us, it was a big learning process around commissioning of services. That's not been normally been something managed at a state level, but that's been an amazing process. Developing our new suicide prevention peer workforce, overcoming some of our history within the service, acknowledging it, and how do we learn from it moving forward? And some of that sort of traditional barriers that occur between clinicians and managers, how do we sort of work on that? And I'll acknowledge that's one that we continuously strive to work on. And particularly for RJLC, with our restorative just learning culture, getting more online and workshop-based processes with our leaders, getting them all into the room routinely has been sort of one of those big game changers for us around keeping the agenda on board around restorative just learning culture, which I've not really been able to talk too much at the moment, but it's something that we're constantly working on. I think the things that we're still working on is the workforce shortages, definitely stigma around suicide and how it's more than just a mental health related. process. Our job is to lead on this matter, but not to obviously own it, but we do really take that leadership responsibility on board. And I think the other thing that we're still working on, but we're getting a lot further on board with, is our fragmentation with some of our aligned type services on this journey, our drug and alcohol colleagues, trauma services, just so that we're actually all working the same way continuously from a consumer perspective. So thank you very much.
Thank you, Adam. That's great and inspirational. So great work in Illawarra. I know your suicide prevention officer quite well from doing some as well. So good work. Next up, we have Meryl White. Meryl is the Director of Transformation for the Mildura-based Public Hospital Area Mental Health and Wellbeing Service. She has been instrumental in leading the transformation of this service following the widespread recommendations following the Royal Commission into mental health services in Victoria. So please welcome Meryl White.
Thanks so much, Matt, and thanks everyone for having me today. It's been really interesting to listen to how other states have approached implementation of zero suicide into their own hospital or health systems. So I'll talk through our experiences of being 15 months in to implementing zero suicide framework in our hospital in the context of the Victorian mental health and wellbeing system reforms after the Royal Commission in 2021. But first, I'd like to acknowledge the Latchi Latchi and the Barkindji people who are the traditional custodians of the lands upon which I'm speaking to you from today, and pay my respects to elders and ancestors past, present and emerging, and honour their culture, and also pay my respects and acknowledge those with lived and living experience of mental illness and psychological distress and the wisdom they bring to the table in it as we transform our mental health systems. So before I talk a bit about how we've approached leadership and implementation of zero suicide framework, I just wanted to set the scene a little around the context in which it lands, and that's a context of a system which is in immense amounts of change and transformational change at this time. So the Victorian Royal Commission into the state's mental health system, it came to an end in 2021, had 74 recommendations for change, all of which the state government is undertaking to implement. And for us in hospitals, that is nine priority areas. Over the last 3 years, we've been tasked in transforming our services. And just listening to a couple of the prior speakers, integrating lived experience, looking at our connections across the service system, embedding integrated alcohol and other drug treatment for those with co-occurring conditions. These are some of the things that we're actively reforming our service. And that transformational change has occurred in the last 3 years and is still occurring. And it's been it's involved in some cases, and for us in Mildura, a complete organisational restructure and the establishment of new service tiers in our region, such as the mental health and wellbeing local. And as a transformed service, Mildura commenced operating as an area mental health and wellbeing service, hospital-based, in January this year. So why are we implementing zero suicide framework at Mildura in the context of all this other reform? I've got I suppose a quote here that our hospital has been looking for ways we can continue to improve the experience we offer those with suicidal thoughts and their families, carers and workforce. This is a natural step for us based on some prior work that we've done in the region, and I'll talk about that in a moment. And we saw partnering with Safer Care Victoria and the Mental Health Improvement Program and implementing the zero suicide framework across our service as a way to really embed some of the change that we'd already commenced as part of prior work. What is that prior work? Both Catherine mentioned the lifespan framework, the systems approach to suicide prevention, and Adam, I can see some of the aspects of the work that are happening in Illawarra and Shoalhaven are aligned to that framework as well. And Mildura was the site of a place-based suicide prevention trial using that systems approach, the lifespan framework to suicide prevention between 2017 and 2022. So it was a five-year trial where we looked at how to strengthen all the aspects of the lifespan framework in our region. At the same time, the Victorian government tested aftercare and had the hospital outreach post-suicidal engagement aftercare trials, and we were a trial site for those services as well, and they've since expanded across the state. So those two pieces of prior work really set us up with a good foundation from which we then moved to looking at I guess, a natural next step in implementing zero suicide framework within the hospital, particularly as it speaks to the evidence-based treatment and the points of intervention in the suicide prevention system that sit with healthcare. And it has a lot of resonance and I guess synergy with lifespan. But as Catherine said, it's not a replacement for a whole of community systems approach. We see it as being something that helps us conceptualise how that happens in our healthcare settings. I just wanted to share this particular screen. Just you won't be able to read all the content, but just to give you the overall feel of applying another layer of transformative change on a system that is in immense processes of transformation. So this is the timeline, I guess, of our work in Mildura from July 2022 up until January 2025, and each of these aspects here is quite a significant piece of transformative work in our mental health sector. And down the bottom there, you can see in December 2023, when we began the journey of the Zero Suicide Framework implementation. And I just show that to show that, particularly in Victoria, and I'm sure this is the same in other states, mental health services and health systems are never static. There's never nothing happening. And we embrace the implementation of this framework on top of a whole heap of other change, but we've also tried to therefore build it in a sustainable way into our new models of care, into how we move forward to make it fit with all the other moving parts. And that brings me to leadership. And I think we've chosen in the 15 months that we've been working with Safer Care Victoria and the Zero Suicide Framework implementation, our leadership perspective is really coming from three different principles. One is that a belief that we can embed in our leadership that improvement can be achieved for consumers at risk of suicide and their carers and supporters, and that improvement can be built across all touch points of our hospital, but also as we're a remote and relatively isolated regional area, we can eventually work with our sector to improve the experiences of consumers in the Northern Mallee by building suicide pathways that go across our region. We are definitely taking a systems approach. It's the way that we've worked. I've come into the hospital from coordinating our place-based trial, so it's a very, very familiar approach to me, and we are aiming to look at our system and intervene in our system as a whole. And that's a big challenge, particularly when there's lots and lots and lots of change happening. And our other principle is around supporting training and wellbeing, and through the provision of the high quality training and support for staff with a focus on their wellbeing as well. How does zero suicide framework sit across our system? The figure I've got up there is the Mental Health and Wellbeing System Victoria is moving to post-Royal Commission. It's a 6-layer or 6-tier system. We are level 5 in the area of mental health and wellbeing services, so that second one from the bottom. And we are also partners in delivering and supporting the level 4 services, the local mental health and wellbeing services, which are a brand new layer in our system. And so our work in implementing zero suicide is thinking about it across those 2 elements of our mental health system, but also across our hospital in terms of our emergency department, our medical wards, and our Aboriginal health unit. And it's I guess a challenging space to think about it just from the hospital point of view, but then thinking about our interactions in the different settings as well. So that's a longer term, I guess, goal for us. At the moment, we're focused on how we can embed just within the hospital, and then we'll gradually move out into our other partner layers. So what story do we have to tell so far? And we're only 15 months in. What's worked for us has been really building upon that prior system-wide suicide prevention work in the Northern Mallee. The trial and the HOPE, the place-based trial and the HOPE trial really did provide a really solid foundation from which this is a logical next step for our region. The implementation of zero suicide framework within our healthcare setting has really supported us in increasing awareness of systems approaches and also evidence-based interventions for suicide prevention, and in particular expanding that knowledge in a small initial way, because we're quite at the early stages of our journey, into other parts of the hospital as well outside of mental health. We've built elements of ZSF into our model of care, our transformed model of care for our area mental health and wellbeing service, including embedding it as a portfolio at a director level in our service, so that it remains front and centre. The reflective practices have been very useful in clarifying gaps and hospital touch points for us in our suicide prevention system, making them more specific. And taking an improvement approach has been valuable in encouraging and skilling people up in particularly ways of thinking, evaluative and critical ways of thinking, and also in measuring initiative. You know, if we do something, how will we know whether we've made a difference or not? That's been really useful. Having the director level and lived experience staff involved has definitely helped us have more traction across the hospital, and particularly the support we've had from Safer Care Victoria and the Mental Health Improvement Program staff has been very invaluable. What's been challenging has been doing this additional reform work on top of a reforming system. And I think when we embarked on this, we figured, well, what's one more thing to change? We've got so much to change, why not add one more thing? Having the gaps clarified in this process for our hospital and for our system, and having those more specific, has actually been challenging, because we haven't yet been able to readily or effectively intervene in those gaps. And so that holds us in a place of discomfort from which we will move forward, but yes, it's a challenge as well. Sourcing and tracking data and creating effective communication and feedback loops, particularly when there's so much else going on. It can be difficult to cut through with the zero suicide messaging. Having a small improvement team without dedicated project resourcing is obviously a challenge, and the improvement approaches have been a benefit and in some ways a challenge in that probably they led us in some cases to focus into sort of the nitty-gritty detail and then not zoom out again in timely ways, but we're learning how to manage that a bit better, I think. What do we need to think more about? I think, as I've said, there's some of the challenges. There's some aspects of implementation that we thought we would have done that we haven't, and that's because we've sort of adapted as we've gone. And one of those is going out to survey our staff and consumers and carers again when we've already know what the gaps are and we haven't yet been able to intervene. I think it's as I said before, linking our sort of improvement cycles related to ZSF, the PDSO cycles back to those identified gaps, and potentially starting with a system pathway mapping as a precursor to those improvement cycles, enabling us to zoom out again. What's next for us? We are aiming to develop a suicide prevention pathways for our hospital and eventually for our sector and our region. We're small enough to do that, and using those pathways to really help us sort of prioritise and focus our interventions through the framework and help with our data collection. And some of the things that others have spoken about before, safety planning, transitions, etc., are also on our list as well. One of the things that we're very excited to be imminently doing is to roll out and evaluate suicide risk assessment and management in emergency departments, the SRAM ED training that was developed by the Queensland Centre for Mental Health Learning in our hospital emergency department. This one's been a long, slow process of getting this across the board. I think we started this in COVID and now just looking at being able to roll that out. And we will continue to test and adapt and keep on trying as we go along to implement the elements of zero suicide alongside the reforms that are happening in Victoria. So that's, I guess, the essence of where we are in Mildura. We're a short way into the process and we are committed to continuing, and very happy for questions at the end.
Thank you so much, Meryl. That's amazing. An awful lot. Congratulations on some great leadership there, particularly a reform approach across a rural area and how it fits in the broader system was really interesting. Thank you for sharing that. Our next speakers, we have Associate Professor John Brayley. He is the Chief Psychiatrist in South Australia. He has supported many initiatives in suicide prevention, including the formation of the South Australian Suicide Prevention Act, which is a first for Australia. So please welcome Professor John Brayley.
Thank you very much for that introduction, and hello everyone. Before I commence, I'd like to acknowledge the traditional landowners, and I'm here in Kaurna land in Adelaide, but also acknowledge traditional owners around the country for this national meeting. I'm going to talk a bit, I'm talking on behalf of a relatively small suicide prevention team and others in the office who work in the area of suicide prevention. I'm going to talk a bit about legislation and improvement, the use of safety and quality data. So we're not going to be talking specifically about means or anything like that, but there is the numbers that are going to be presented are quite significant, and so I think people need to look after themselves when looking at data such as this and speak to people if that sort of information has impact. Looking at towards zero suicide prevention in South Australia and the development of a suicide prevention pathway standard. So first of all, as mentioned in the introduction, we do have the Suicide Prevention Act in South Australia, and this sets up the Suicide Prevention Council and a state plan. And it also enables the Chief Psychiatrist and the Chief Public Health Officer to make recommendations about preventing means. And some of the work that our teams have done in that area, working with other government departments, private company, and to look at means reduction. While it has a community suicide prevention focus, it often links to the work of our services as well. They can be in terms of becoming aware of linkages through incident reviews. The other bit of legislation I'm mentioning there is the Mental Health Act. Enables the Chief Psychiatrist to set standards. And after discussions with chief executives of our local health networks, we have embarked on a process of developing a suicide prevention pathway standard, basically saying that services should have a suicide prevention pathway in place. You know, we'd expect the same for a chest pain pathway or some forms of trauma pathways, various other conditions where pathways are generally accepted. So we should be looking at the same thing for a suicide prevention pathway. And then linking into the work of the Towards Zero work and the suicide prevention work has been our reviews and investigations. And examples have been work both following coronial recommendations and our own reviews about looking at alcohol responses in pathways, and also the importance of starting the suicide prevention pathway at the earliest possible opportunity, whether people are seen by ambulance or at arrival in the ED. Now, this graph looks at deaths of people by suicide in South Australia. Since we had, and these are people who are non-inpatient community clients, either of emergency services or mental health services or community teams. In 2019, our suicide register started operating. So for the first time, we were able to get an accurate number for the number of people who've lost their life. So like any other health service, suicide prevention is seeking to reduce mortality associated with healthcare. The definition we use is anyone who's had contact with our services in the last 6 months. There can be different definitions in different jurisdictions. In the UK, we'll go to 12 months. Some other places, other jurisdictions in South Australia can be shorter. So this accuracy is helpful in terms of seeking to set targets for reduction. We had a reduction in 2024. It's not clear what that means, but we know that there's been a lot of training, a lot of focus on suicide prevention in services. I'm aware of one other jurisdiction that was also seeing a reduction in the number of people who'd lost their lives. So I think having the suicide register complements this work because we're able to notify our services of deaths that they might be unaware of. This is a graph of attempted suicide, deliberate self-harm, and you can see it starting a number of years ago. This line here is the critical line. In early 2022, we had a significant increase in the number of attempted suicides that are occurring within our services. Now, most of these are inpatient. This covers ED, general wards, mental health units. It's starting to subside a little bit. But these are quite significant events. If it wasn't for the prompt action of nursing staff in many of these situations, lives could potentially have been lost. So why did this increase occur in early 2022, which coincided with our state opening up to COVID at that time? We never got to the bottom of this, but it just highlighted the importance of the general suicide prevention work that's occurring. This is the same data showing the increase. This is another deliberate self-harm graph there. So coming down, but we need to be very careful in hospitals, mental health and non-mental health areas with these added risks associated with people experiencing significant distress. The other thing that this is from a graph in our annual report looking at deaths by suicide and cause of deaths undetermined. It's not a constant number over the months, and for some reasons, at times in some years, we seem to have peaks at a very similar time to the year that our emergency departments in South Australia are busier as well. Understanding that relationship is an important thing to consider, but we can't draw any conclusions about that. This is just a list of the standards that we have from the office. We've completed the suicide prevention pathway standard. It's actually just about to be rolled out. It's been a long process with consultation, co-design, work with sector, lived experience providers, various professional organisations, a major consultation. And this will help set the scene. Now, just for the context about Towards Zero Suicide in South Australia, it's part of our current mental health services plan. And I guess we're inspired to do it after a suicide prevention conference that was in Adelaide that had David Covington and Catherine Turner presenting. This is what we needed to do. It raised a few eyebrows when we started talking about it initially. We've had a group of committed staff who've changed over the time working in this area, getting support from other jurisdictions, workshops focusing on the pathway, restorative just learning culture, various forms of training, and the standard and an associated guideline have been, in a nutshell, some of the key activities. So the standard that's about to go out will cover SA ambulance and gazetted facilities. So that's public and there is one private hospital as well as our local health districts networks. And the expectation is we're not setting a statewide standard, a statewide pathway, but the expectation is that each service has a pathway and that it addresses these key areas which are common to the pathways that are being implemented nationally. I think I'd just like to acknowledge some of the key people who have worked in this area, Dave Thompson and Sandy Terry from our suicide prevention team. We've had other people also in the team previously, a committee with providers, lived experience. We're in the background in a way. We're facilitating it. It's the frontline people in services that are doing the critical work, and we hope that we can help eliminate barriers and create an environment. Sue Murray's been very important to our work here, and the link with safety and quality and data analysis, has been helpful, along with the international links and through the Zero Suicide Network. And we've been very grateful for the departmental support for this work. Thank you.
Thank you. It's amazing work. It's really good perspective from a chief psychiatrist, looking at some of the reform actions you've been taking there in South Australia. Good stuff. So we're now going to move on to, I'm going to introduce you, AD Gibbons and Dr. Mohammed Usman, implementing the Zero Suicide Framework within a child and adolescent services. It requires a number of adaptations, of course, even more so when it's at the added responsibility of being a statewide service. So no pressure for those guys. So Dr. Usman is Clinical Director of CAMHS in South Australia and co-leads this service with Miss AD Gibbons, the Director of Strategic and Mental Health Operations. So please welcome Miss AD Gibbons and Mohammed Usman.
Well, thank you for that. And we are under pressure because our technology is not helping us. So apologize for that, but we'll get through this. I'm Mohammed, psychiatrist here. I've got AD with me, and we just want to talk about CAMHS as well as what we have achieved in CAMHS in the relatively short period of time. But before I begin, I just want to acknowledge that we are in the traditional lands of Kaurna people, and we acknowledge their respective relationship to the land. And next slide. And sorry, we're just going to the next slide. So that's a technology issue. The next slide will be about acknowledging the lived experience. And the next slide, we're going to talk about a little bit of CAMHS here. So CAMHS is a big provider of mental health services. It's the only tertiary mental health service provider across South Australia. And we provide a range of services which are focused on multiple areas, which includes the core issue at Central Adelaide, as well as in regional and rural areas. Our focus remains on identifying mental health issues and addressing in a very therapeutic framework, which we are very proud of. The next slide, I'll explain the number of different services we have, which includes, and we've just kind of conceptualized this to make it easier. It's not quite this easy, but for our conceptualization purposes, we have, sorry, I lost the slide, but we have an acute inpatient service, which provides admissions to people under 18. And we have emergency mental health services, which is based on the hospital, as well as multiple other services in the hospital, including a specific developmental disability service, eating disorder services. And we also have a perinatal infant mental health services with an inpatient unit outside of this premise. Other than that, we also have specialized services such as forensic, and a majority of the services are delivered in the community, particularly across multiple sites and regional areas as well. Underpinning all this, we are very proud of having our Aboriginal mental health workforce embedded across multiple teams across the state. As I probably alluded to, the biggest thing we are very proud of is our workforce, which is probably in the next slide, that explains us we have around 360 staff, equivalent of it, with varied workforce, including psychiatrists, medical, Aboriginal workforce, allied health. It's probably important to say a total population of children, which is under the age of 18 in South Australia, is around 375,000, with around 21%, which constitutes around 21% of the total South Australian population. So if we equate that to the number of staff, obviously we are only providing a very, very small amount of service provision across a wide geographical challenge. That's one of the biggest challenges on how we provide that. So we use various modalities, which includes face-to-face as a predominant modality, but in areas such as APLNs and regional areas, we also provide telehealth. But that sometimes is accepted, sometimes it's a bit challenging, but we try to provide as much as possible in the regional areas with telehealth and face-to-face as a combination. Next slide, please. When we started looking at the problem of Towards Zero Suicide, which obviously an initiative of the Office of Chief Psychiatrist. We started looking at what does it mean for CAMHS, and we know that a suicide in children affects vastly different to an adult population. It's just a family that gets affected. There is a wider community of school, for example, and much bigger than that, the entire community, particularly in rural and remote areas. There is a devastation that's just going through the entire community. And this is even very challenging for people from Aboriginal population, where it's recognized that the rates are higher. Next slide, please. We looked at the next slide, please. We looked at the issue specific to South Australia. So we looked at the data from South Australian Child Death Review Committee, and it was fairly clear, as you can see towards the purple color towards the end, the deaths of suicide between the ages of 10 to 15 is one of the highest cause of death in young people. Next slide, please. Identifying this, we also have Office of Chief Psychiatrist developed a SA Mental Health Services Plan, which talked about what we need to do. We used that framework to begin with, and the next slide, we also used a survey that was done through the Preventive Wellbeing SA, which was a big survey that looked at the public consultation. And I'm just bringing the two quotes there that are important. From our perspective, we picked it up. One is, how do we make our staff feel safe, and what we need to do to help the kids feel safe. These are the two things that we want to work on. And this was a very, very useful document for us to know what the community feels and how we need to address that. So I'm going to hand over to Adi to talk further as what we did. Next slide, please.
Thanks, Mohammed. So we did organisational self-study back in 2022, and from our staff, what we heard was we did have some strengths, and they were around risk screening and assessment at intake, and we had a standardised tool for doing that. We did safety planning, and that was seen as a strength. And we had clinical safety, quality and risk processes and committees in place, including mortality review and escalation processes. The areas that we needed to improve on, there was a lack of a formal suicide prevention training programme, inconsistent approaches to suicide risk assessment across our various services, limited organisational wide standardised approaches, specifically to suicide care, and people were unclear on their roles and responsibilities.
Can we click a few clicks before going to the next slide?
Yeah, so we'll move on to the next slide. So as leaders, how did we respond to that? So we recognise that suicide prevention care is a core business, it's our core business, and it needs to be given the importance it deserves. And that we as leadership are accountable to strengthen the culture of safety within CAMHS, and that the identified weaknesses from the survey were not okay, and that we had to have an all of service commitment to improve what was required. And that we needed to use change management to create a paradigm shift, and that obviously takes time and resources to do. Next slide, which again has a few clicks, please. So our colleague who has been doing the most work on this, Sharon Phillips, who's our project officer, who was sat there but is hidden now, has spent a very long time writing this suicide prevention strategy. And it's an extremely good strategy which outlines our clear but ambitious goals, and it fosters brave decision making. We have to be brave, and we have to be persistent, and we have to keep pushing forward. And it does articulate what we as CAMHS can achieve within our sphere of control, but it also empowers cultural and custodianship and organisational learning across all of CAMHS. Next slide, please.
A few clicks, please.
Again, yeah, sorry. So we had no extra money to do this, but we did recognise that we can't do it on existing existing resources. So we diverted some budget for project and clinical leads, and we have spent some money on an external consultant from the Gold Coast, Sarah McDowell, who's come down and helped us with our training package and also ongoing supervision for staff. And we need to consider what the longer term sustainability is, including supervision structures. So we've now employed 1.5 FTE senior suicide prevention project officers who will be in some ways taking over from Sarah, but we'll be focusing on how to provide that support and supervision to the staff who are using the new training that we've developed, but also to make sure that that's ongoing, that the consistency remains and staff feel supported. So there'll be a lot of one-on-one work and buddying up and mentorship happening there. So we definitely led from the front. All of the executive leadership group had done the training, and we did it alongside other staff. We sat in the room with them and learnt at the same time. We empowered our cultural leads, our Aboriginal principal lead and other senior Aboriginal staff to ensure that the training we're providing in the pathway is culturally safe and sound for our Aboriginal consumers. And we have done mixed group training, so we have done various disciplines from various teams sitting in the same training, and that was a deliberate decision not to do discipline specific. And we're also strengthening our partnerships. So Centacare have a programme here in South Australia where they do assertive outreach with 16 to 18-year-olds, and also our local Headspace, and they have now done the same training, so they come and do the training alongside us. So we're all speaking the same language, and we know that the kids can go between one service and another and get the same care along the same pathways with the same training. Next slide, please. So we know that we need time to embed it as business as usual. We has, as usual in organisations and services, had a couple of teams who were very keen, put their hands up, said, yes, us please, let us trial this. So we trialled that in one of our country areas and one of our metro areas. And it's taken time to get everybody through the training. I think the last training session we have booked for now is next month, and by which time the vast majority of clinicians will have done the training. But we still know that that's only getting us to the top of the hump, and we need to get over the other side and keep embedding this as business as usual. And again, that's where Sharon's role as project officer and the two suicide prevention project workers come in. And we've also spent some time looking for those middle benchers, the people who are there who, you know, they're not the early adopters, but they're also not the ones who are going to dig their heels in. And we know there are emerging leaders and the ones that will keep this moving forward. So we're really working with them, finding who they are and encouraging them to do some mentorship and support, etc., in their teams. Next slide. So we are celebrating some of our successes. We were a finalist in the Women's and Children's Health Network Excellence Awards last year, which was fantastic. And Mohammed and Sharon have also presented at the Child and Adolescent Psychiatry Faculty Conference in New Zealand last year. And next slide is the end. So thank you very much for allowing us to present today.
Thank you so much to Adi and Mohammed there on sharing the Child and Adolescent focus on zero suicide. I commend you for the great work that you've been doing there. We're going to take a different tack now. We're going to speak to Nikki Molinares. I think I've got that right, Nikki. Excuse me if I didn't get that right. So Nikki is a workplace health and safety lawyer with Norton Rose Fulbright. The release of WorkSafe Australia guidelines on the management of psychosocial hazards has resulted in increased focus on this area for health service leadership. It absolutely has. This strengthens the case for leading culture change within health systems. Please welcome Nikki Milionis.
Thanks, Matt. Hi, everyone. Just to start off, I'd like to acknowledge the traditional owners of the land that I'm speaking to you from today, which are the Wurundjeri people, and pay my respects to their elders past, present, and emerging. Thank you for having me today. I'm going to be talking about work health safety and managing psychosocial hazards and risks. So let's see if my tech is working. Lovely. I'm going to take you very briefly through the legislative framework, talk about the very specific regulations, and then some compliance suggestions at the end. Many of you will be familiar with the fact that there's the Work Health Safety Act in every jurisdiction around Australia except for Victoria, and that's why I've got there the Occupational Health and Safety Act that applies in Victoria, and this is performance or outcomes-based legislation. It's not prescriptive in how you meet your duties. However, the regulations which sit underneath the Act do contain chapters with more regulatory or more prescriptive detail, and one of those chapters, importantly, deals with management of psychosocial risks to health. And I'm going to talk about that in a little bit more detail. It should be noted that Victoria doesn't yet have specific regulations in this area, but there's been an announcement by the Victorian government very recently, within the last couple of weeks, to say that draft regulations will be released, we think, in October of this year to commence on the 1st of December of 2025. There are also codes of practice, and I'm going to talk about these a little bit further because there have been a number of codes of practice released in every jurisdiction providing more detail, if you like, about common psychosocial hazards and the ways in which organisations should seek to meet their ACT duties to provide a safe working environment so far as reasonably practicable. And so some of that detail is in the codes of practice. And finally, there are guidelines and standards. This may be familiar to many of you, so I'm going to just breeze through it. Just suffice to say that the Act sets out duty holders. These are some of them. I'm really going to be focusing just on the first one, which is the person conducting a business or undertaking. Otherwise, I'm going to refer to it as a PCBU. And there is many of the duties, but not all of them, on the PCBU are limited by the concept of what is reasonably practicable. And I'm going to talk about that a little bit later. So these are the primary duties, if you like, of the PCBU. And so a PCBU must ensure, so far as is reasonably practicable, the health and safety of workers engaged, caused to be engaged, influenced or directed while they're at work. And then in addition to that, a PCBU must ensure, so far as reasonably practicable, the health and safety of other persons. So quite a broad category, is not put at risk from the way in which they carry out their business. Some of the prime or further detail, if you like, about the type of duty of a PCBU. So provision and maintenance of a safe working environment, safe plants, systems of work, etc. So what is reasonably practicable? Because we're going to talk about that and it's going to come up a couple of times. It's defined in the legislation and it's defined to be in relation to a duty, it's to that which is or was at a particular time reasonably able to be done in relation to ensuring health and safety, taking into account the following factors. I personally prefer the visual representation of what this actually is. So reasonably practicable in some ways is a balancing act between what is known about the likelihood of risk and the consequences if that risk manifests, and then balancing that against what's known. So the knowledge here is objective knowledge about the risk and ways of mitigating it against the availability of means to mitigate the risk and costs. Costs are considered last and only if grossly disproportionate to the risk. So regulations. I mentioned at the commencement that there are now specific regulations addressing the obligations to manage psychosocial risks to health, and they are now in every jurisdiction in Australia except for Victoria, as I mentioned. And you can see there the progression over time of the introduction of these obligations. Excuse me. And there's a specific code of practice in each jurisdiction. Many of them have similarities. They're not all exactly the same. There is a specific difference in the Queensland and Commonwealth regulations, but I'm not going to go into those today. So at a high level, what is the definition of psychosocial hazard? This comes directly from the regulations. And it's a hazard that arises from these kind of four areas, if you like. So design and management of work. And so you will have heard discussions of overwork and being contactable outside of work hours as an example of that. Work environment, plant that's used, so plant and equipment that's used at the workplace, and obviously workplace interactions or behaviours. And that will take into account poor workplace interactions, poor support, bullying, harassment, etc. And a psychosocial risk is obviously one that arises from a psychosocial hazard and presents a risk. So I've set out here some of the common psychosocial hazards. This is not an exhaustive list, and this comes directly from the model code. So Safe Work Australia, if you like, the educational body, has issued a code of practice, and it contains a range of these psychosocial hazards, which are the common ones for you to look out for when you're doing your hazard identification. So you can see some of those there and also on the next slide. So what's the obligation? At a very high level, it is this: to identify reasonably foreseeable hazards, to manage those hazards, and that always means to eliminate so far as reasonably practicable, and if not reasonably practicable to eliminate, then to minimise. And the way in which you do that is to introduce control measures, and then you must, after you've introduced control measures, maintain those and review them, so for their continued effectiveness. What's important to note is for each one of these steps, you have to consult. There are obligations under the Act to consult with workers and their representatives, if there are representatives, in relation to each of these stages. So hazard identification, risk control, risk assessment and risk control. So here are some of the suggestions about the things that organisations should do. Many of these come from working with our clients, but also from the codes of practice, which provide some detail about how you might go about doing hazard identification. So obviously consulting with workers, using surveys, many people are familiar with that concept, considering industry data, trend analysis, sick leave, workers' compensation records, etc. Observations, assessing the physical environment, and also importantly the online environment, that's worth noting, and demographics. And then, of course, once you've done hazard identification, you have to move to risk control, and you must consult in relation to that in order to identify potential risk control measures. The regulations actually set out some of the factors that you need to take into account when considering what risk control measures are appropriate. And these are those measures, those criteria here. So thinking about the duration, frequency, and interaction of multiple common hazards, the interaction of them, the design of work, systems of work that are used, design layout, for example, of physical spaces that people work in and that other persons have access to. And you can see there information, training, instruction and supervision that's provided is at the end there. So some of the things that we suggest to our clients for consideration and expectations, if you like, of the regulator would be that there has been a psychosocial risk assessment that's been conducted. The outcomes of that will have found its way into a risk register so that it can be monitored and maintained over time. Obviously that you'll have undertaken the hazard ID risk assessment portion of this. It's likely to flow into new systems control because of course this is looking at eliminating systemic issues that contribute to the existence of psychosocial risks to health for your workers and other persons. So looking at potentially new policies, new procedures, many of those will focus potentially on HR processes, but not exclusively, obviously. Implementing a consultation program if you haven't already, and obviously instituting training programs in relation to identifying psychosocial risks to health or the hazards, how they might become risks, how they're controlled, how the organisation has implemented measures for their control and how those are to be used and maintained over time. That is a very fast whiz through of work health safety. I hope that was helpful.
Thank you, Nikki. That was great. I think it's certainly a topic that we need to start paying a lot more attention to in the future. So thank you for sharing that. Really pleasure. So next up, we have Kieran Kinsella, who is the Executive Director of the Metro South Health Addiction and Mental Health Service in Brisbane. Kieran recognised the importance of providing staff with a safe work environment in which people are encouraged to speak out. And in support of this, he's established the Never Alone program within the health service. Please welcome Kieran Kinsella.
Super, thank you, Matt. I'm also having some IT difficulties, I think. Bear with me 2 seconds. We have done that, but it didn't work. Share screen. Entire screen. No, it's not. I can't see my presentation. I can go without presentation. I can just stand and talk, if that's all right. Cool. Thank you for the opportunity to come in and present. So I'm going to talk a little bit about our Never Alone program, but also a little bit about why that program is important within addictions and mental health in Metro South and broadly in terms of kind of suicide. Now, before I kind of jump into it, I'd just like to acknowledge Aboriginal Torres Strait Islander people as the traditional custodians of the lands and pay my respects to others past, present, future, and emerging. In terms of kind of zero suicide and why kind of the initiative is important to me, and I've been really lucky. I've been in Queensland Health since its beginning, so back in 2019. I've had the opportunity to work both in Central Queensland and in Brisbane implementing the program. And like I think that we say the phrase a lot, kind of one is too many. I kind of reflect on some evidence around every suicide impacts about 135 individuals. And I know just from kind of professionally, I'm a mental health nurse. I have worked with consumers who have completed suicide, but also personally, I've had some friends who have completed suicide. So this initiative is kind of really something I'm really passionate about, ensuring that we kind of continue to progress with. We talk a lot about our restorative justice culture, and I know we've had several presentations this morning about it. And I won't kind of dwell on it, apart from to say, I think the challenge of implementing it is a real challenge. The aim of restorative justice culture and learning culture is to ensure that our staff experience that. And that's where I think the challenge of implementing it is. We can do all the things and have all the structures at a leadership and service level, but sometimes we're in the staff group that just don't experience the service in the way that we intend them to experience it. And I think there's several reasons for that. So one is a previous experience that staff members had. So staff members could have worked in organisations that are a bit have blame or aren't very restorative. So there can be a lot of scepticism about people like me and other managers coming out and talking about restorative justice culture. So past experience. We work in a system. Of course, we've got KPIs, we've got budgets to maintain. So you can have this kind of conflict, I think, sometimes where we have a suicide within the service. We talk about being restorative for all our staff. We make a really big deal of it. And then in other parts of the work that we do, our actions might not be restorative. And that can kind of cause, I think, some conflict with staff, because they, of course, experience the whole workplace. They don't just experience it in segments. And then, of course, we're a hierarchical system. So we have managers who can direct the work that we do. So again, it can kind of make that kind of culture difficult to embed within the service. And then the final thing that I think kind of makes it particularly difficult is that we are humans working with humans. So we can all have our off days. I have found at times that, particularly when you're trying to do culture change, that some of the skeptical people are waiting for the chink, and that chink can be a statement, a look, or a comment. And then you can sometimes get, see, I knew they weren't committed to restorative justice culture. So there's a real challenge, I think, around just how we are every day, because we can come to work and have good days, bad days, good moments at work, bad moments at work that can all impact on the culture. So we can get it wrong despite our best intentions. And I'm just going to talk about kind of two examples of that we've had from staff when we've gone out and spoke to them. So one is around communication and how we communicate. And one of the things that we continue to work hard on, because we still haven't got it right, and I don't know if we'll ever get it right, we just have to continue to work on it, is how people get informed around a completed suicide of a consumer within the service. We struggle sometimes with, do we call staff on their day off? Is that an appropriate thing to do? Because we can then control how the member of staff finds out. we've had instances where an external agency on our statewide record system has recorded that the person is deceased, and the case managers found out when they've logged into the clinical record. So kind of just poor sharing of that information, that really critical information, because for some people that might be the first time that they receive that, and we do hope that our clinicians over the course of their career don't receive that information too often. So trying to get that right is really, really challenging. And we've actually had one of our staff kind of say to us that when we try and keep it closed and speak to the case manager and the consultant that are directly involved, they feel that that's nearly stigmatizing suicide, and that we should be more open, but of course you can't do an open broadcast. So we struggle with that a lot and haven't got a solution. The other one that kind of has caught me out is when you have one of the things you would hear often when we're reviewing a case is a senior leader would come on and go, I've had a look through the clinical record and everything seems to be in order and we're not concerned about the care. A case manager who had that said to them said to me that what they hear when they hear that statement is, I've had to check because I didn't trust the work that was in place, and the work is okay, so we don't need to worry. The initial reason for the statement was a supportive reason, trying to say to the staff member, all's good, we've had a look, but the staff member seeing that as a kind of nearly a blame process, say you didn't trust me. So again, kind of the learning that I've had from all this is just how hard it is to get it right for every individual, and I don't think that you can. So things that we're doing, so orientation, we talk a lot about restorative just culture. I talk a lot to the all new staff around our continued efforts for it, and we ask for genuine feedback on that. We present kind of genuine curiosity to our teams and kind of ask them to feed that back to us, and I think we are seeing some examples of that in the examples I just gave. We're also working with all our new grads around prevention, so explaining to new grads and new people in the health system around what happens if there is a completed suicide in the service, so they have kind of pre-warning for that. We hold a triage meeting, and we now invite clinical teams to that to discuss the clinical incident. We ensure that we have informed everybody that we need to inform and get feedback from the case manager, team leader on that. We also discuss what level of investigation we're having, and the clinicians get to have an input into that. So we try and have the process as transparent as possible. And then we publicize our Never Alone program. So we worked hard, launched this about a year ago. I think it's one of the things for me around kind of zero suicide is that kind of peer support. And I know Kathy spoke earlier, and Gold Coast have been doing this for several years. But we asked for volunteers and staff who would want to support colleagues who had experienced a consumer who completed suicide. There's no requirement for staff to reach out, but we provide that information for them to do. And the purpose of it is to support staff through what might come next in terms of the investigation, but more importantly, just to be a listening ear. So it's not a clinical intervention, it's kind of a peer-on-peer staff support. It's open to all staff, so we don't restrict it to just clinical staff, because we're very aware that it's not just clinical staff who interact with our consumers, and in fact our administration staff and even on wards, our operational staff will have a lot of interactions with our consumers as they come through the system. So the Never Alone program is open up to all staff, and there's no time limit. So we say to our teams, 6 months, a year, 18 months after a completed suicide, if you are feeling that there's something unresolved, or you are feeling like you would like to go and get additional support to have a conversation, the Never Alone program is always there for you. So we don't say once 6 months has passed, you can no longer access that. For us, it's a really exciting program. It's really, well, I think the power of it is having clinicians within the service supporting clinicians, and the feedback that we get is people really appreciate that opportunity to help and be helped by their peers. I know a few presenters have kind of learned one key lesson at the end. My kind of one is kind of never give up striving for a Jersey learning culture. I think there's a lot of challenges within it when you work with big workforces, because all individuals are different and perceive things differently. But as a leadership team, we should never give up. And I think for staff out there, kind of allow your leadership team to sometimes get it wrong, because they in general, their leadership team will be doing their best to get it right, and provide that frank and honest feedback so they can kind of correct what they've learned. Thank you.
Hi, so we're just going to take some questions now from all our towards all our presenters. I actually can't see the questions, so could someone put the questions up for me? Please do. Yep, that would be good. I'd just like to thank you all, by the way, while we're on the interim. Some great work out there. It's really inspiring. Thank you very much. Just waiting for an email.
Do you want me to ask a question?
Okay, we've got a question for Adam Bryant. So,
Okay.
Adam, in what ways have you been working clinician versus manager mentality? You can also take questions on notice, by the way, guys, as well. If you need to.
I think a lot of it ends up being around having visible leadership within the organisation. We've done a lot of work, particularly over the last 18 months, around making sure that we're regularly across all the services. Obviously, in mental health, we end up being spread across a lot of different areas. We're in 3 different hospital sites. We've got 14 different community sites, and then there's obviously the individual teams from there. And making sure that we've got a regularly published calendar where we can go out and sit within the teams, and not just being obviously. There's a lot of busy work that keeps us engaged, obviously from a more strategic level and at an operational level, but actually making sure that we're visible in those teams regularly. It's been a large part, and having those individual conversations.
Great, thanks, Adam. I've got a question for Adi. Still here? Yep, she is. Is there any research data re-suicides across the state, irrespective of whether or not the person has had contact with the service prior, and what are the broader factors to enable broader support actions?
I'm going to hand over to Mohammed for that one.
Sorry, can you repeat the question? I might have to take
Absolutely. So
yeah.
is there any research data regarding suicides across the state, irrespective of whether or not a person has had contact with the service prior? So I think they're looking at more broader suicide
So I think
numbers,
so I'm going to
etc.
answer that. I think that's actually a question that John Braley could answer better than we can as the Chief Psychiatrist for South Australia.
Let's move it over to you, John. Are you happy to do it?
I'm very happy to do that, and I think acknowledging the significant role that registers can play. Well, they're called suicide registers, but they're actually suicide prevention registers. The AIHW has supported a number of jurisdictions to establish those registers. Ours in South Australia is with Preventive Health SA. We meet regularly with them because it helps identify postvention opportunities, either for individuals or communities. The ability of the register to identify clusters is important, geographic clusters, other groups. And the sorts of information that over the years that we've been able to get out of the register has been really quite significant in terms of means. So without going into the detail, on a couple of occasions, we've been in contact with the TGA, at least one other state has as well, relating to means issues. One of those was highlighted through the register, and it helps us identify places and to visit, or working with other government departments. And one of the things when you're even quite informally, when the team sort of does a bit of geospatial mapping of linkages between people, you might see some people who are clients of the service and other people who are not, but it's really important to understanding the risk. I've only presented our clinical data today, but the suicide prevention register with a public health approach and an individual approach is valuable.
Thank you, John. Appreciate that. We have a question for Kieran. So, Kieran, first of all, there's a comment for you, Kieran. I just want to read that out. It says, "So good to be affirmed as all being human. That's where a forgiving culture can help staff." That's a really good example of trying not to contact staff on days off while still providing them with enough information and supported post-vention. It does sound impossible to get right. The name Never Alone is great. Love your post-vention peer support program. So I just thought I'd get that, set you up, and then the question.
Thank you, Matthew.
Smoothed you into this. The question is, in what way are clinicians involved in the reviews? Is it through interview or are they part of a panel?
It depends on the review. So we have moved away as much as we can from root cause analysis review, because we kind of find that that's probably more clinician interviews. And what we do more often than not is that the clinicians with maybe an external kind of facilitator will sit around and review the case notes, and then they will be involved in reviewing the care that was provided by the whole team, and then suggesting the recommendations as well for improvement in the future. But say we have that discussion at triage meeting with the clinicians, so they have the opportunity to do that.
Brilliant. Thank you, Kieran. Do we have any more questions there, Sue? Okay, no more questions for the time being. I'm sure we'll get some that come through, and then we'll forward them on to you, and we'll keep them as a resource. So thank you so much, everyone, again, for your presentation today. It's very inspiring to hear leadership talking about this. We don't often have leadership here talking about this, and that's why it's so important for you to be talking today. Often we have the project officers talking. So thank you very much, and hopefully that inspires other leaders across the country to adopt zero, or at least a suicide prevention reform approach anyway. So thank you very much. We're just going to do a bit of a wrap up now, and I'm just going to bring Sue back in. Hi, Sue.
Hey, hi, Matt. Wow, what a morning it's been. So certainly I have to say thanks also to all the speakers who really gave of their time and their expertise. But you know, we've gone through the case for change. We've tried to reinforce the importance of that lived experience leadership. We coupled that with your own clinician's view about the need for the case for change. And then we got in to have a little look at our the place that we sit in that whole international program. So good to know that we're not trying to deliver this just within our own little environments. It's really great to know that we're part of such a large program. I think Brian said 20 plus countries that are now looking at how the framework can be applied within their context. And then we zipped over to hear from the excellent Professor Sidney Dekker, but he was backed up by that really practical discussion that Michelle Galley gave us, and the way that she got started, and certainly reinforced the importance of speaking locally. You know, this is not something that we just turn the tap on in every health service. It is, how do we work with our own teams to understand how we can bring those restorative practices into our everyday work plans. And, you know, I think I just heard a webinar the other day in which a chief executive was reinforcing that idea of servant leadership that Sydney talked about. We're not really, as leaders, we're not really there to do anything other than make frontline work possible. And that has all sorts of implications, of course, but it is that critical role that we play in making frontline work possible, and to ensure that people feel safe and secure to be able to raise issues with us as leaders. As I've heard Sydney say, as a leader, you need to be able to sit back, relax, and hear the bad news, not respond immediately, but to then think about who's been involved, what do they need, how are we going to help them, and whose responsibility it is to meet those needs. And then this afternoon, it's certainly been a jam-packed session with our organisational leaders, and I can't say enough how much we appreciate them taking time out of their busy schedules to report back to this to our audience about the sorts of motivations, the challenges, and some of the solutions that they've been able to bring to the table. But I think it also has reinforced just how important it is for those who are designing and planning the zero suicide healthcare implementation, how they have that executive sponsorship to be able to make sure when decisions need to be made, there's a champion right up there in the executive leadership team who will speak the case for making those changes. So all in all, it's been, I think, a great start to our 2-session format. So I'll pass back to you, Matt, for your comments.
Okay, yeah, look, there was some great information shared today. I love John's information about them starting up a suicide register. I think that's a great start. Information is very key, and knowledge. Love the work of Mohammed and Adi Gibson in that child and adolescent focus as well. That's a really tough area. So you guys doing a brilliant job down there. I know Sarah very well, and I hope she's done some really good work with you. I'm sure she has. I would like to mention Kathy Turner as well, sort of reinforces the fundamentals of leadership in suicide prevention reform and articulating really what Zero Suicide Framework is and how it works successfully in mental health services, even alongside more broad reform as well. Adam in the Illawarra Shoalhaven, great stuff, great work you've been doing down there, and support for your aftercare, safe side, suicide prevention manager, and motivation for leading change across the service. I think that's really key information. And Meryl White as well, transformation down there in the Mildura base. Loved your reform approach, talking about the whys. She had a really nice transformation reform timeline. I love a nice picture, and that was great. I really liked that, enjoyed that, and certainly what's worked well and some of the challenges as well. Nikki, I think, you know, this is an area that I think in health services we need to take more notice of, and I think it does come hand in hand with restorative justice and learning culture as well. So thank you for sharing your legislative and legal obligations for Work Health and Safety Act. We need to pay attention to this. I think is heed that warning, and I think Kieran at the end there talking about how you implement this and what it means on the front line, really helping those clinicians and taking, as that person have said, making people feel human. And I think that's great. I think that's a great approach. So yeah, they were the big highlights for me. If I've missed anyone, I do apologise. But you're all great presentations. Just want to say that this is the last obviously session for today. Thank you again for everybody for joining us. We will reconvene next Tuesday, 1st of April. With the second session of the forum. So the focus for that session will be involving participants in a discussion on topics that you've identified as being important to the successful implementation of the Zero Suicide in Healthcare Framework. So if you've not registered yet, on your screens now, you will see a QR code on the screen. So a big thank you to everyone that's joined us today. And a big thank you to our presentations, our leaders, and for everyone who's been involved in pulling this together. So take care, everybody, and we'll see you next week. Cheers.